Why has there been such resistance to low-cost, off-the-shelf therapies that might stop the progression of COVID-19 and help keep people out of hospitals and intensive care units? Since the onset of this pandemic, I have publicly advocated for allowing doctors to be doctors, to practice medicine, explore different therapies, and share their knowledge within the medical community and with the public.
Thank you, Chairman Johnson, Ranking Member Peter, and members of the committee for allowing me to talk to you today about the critical need for early ambulatory treatment for COVID-19 as an emergency measure in the middle of this national crisis. As we sit here today, we have the greatest mass of infected Americans that we've ever had since the start of the pandemic, and Americans are pouring into hospitals untreated. The hospital census is already at capacity. A national calamity of unimaginable mortality is right around the corner. In a matter of weeks to months, Americans are going to be horrified with what they see on the news with respect to a hospital overrun, mortality skyrocketing for both COVID and non-COVID complications and conditions, and patients further infecting other Americans as this pandemic spirals out of control. My viewpoint and my views expressed here are those of my own and not necessarily my institutions. My viewpoint is this pandemic should have always been viewed as having 4 pillars. If we can bring up the figure. The first pillar is contagion control. We have had probably the vast majority of government efforts solely focused on contagion control. The entire media representation of what the government has been doing has been on contagion control. Well, as we sit here today, it's obvious contagion control has not solved the problem. The second pillar is early ambulatory treatment. This virus infects individuals and they sit at home for 2 weeks. We have a 2-week opportunity to treat this problem, and we hear nothing about it. We hear nothing about early ambulatory treatment. There's no updates. There's no viewpoint to Americans of what's going on outside of the United States, where early ambulatory treatment is a standard of care in countries that are doing much better than the United States. It's grossly overlooked. The third pillar is the hospitals, and I've already told you they're overrun. We're doing all the best technologies we possibly can in the hospital, but the hospital's an inadequate safety net. The current hospital mortality rate's about 5 to 7%. When patients get in the ICU, it's 25%. And virtually all the COVID deaths that occur in the hospital. It's obviously not an adequate safety net for Americans. The fourth pillar is vaccination. Vaccination should bring out the close to the pandemic. But this hearing is about early ambulatory treatment. If we can bring up the next figure. We've learned a lot about the virus. There have been over 75,000 peer-reviewed publications in PubMed since the onset of the pandemic. Information is flowing in at about 500 papers a day. So any expert who claims that a review of data and studies is contemporary, they're quickly out of date. And I can tell you with this pandemic and this virus, what we've learned is that there's an early viral replication phase followed by a destructive immune activation called cytokine storm, and then blood clotting thrombosis. And what doctors have done is they've innovated and they've identified, both in the hospital and outside of the hospital, aided by clinical trials and observational studies, an approach that involves combination antivirals followed by corticosteroids and antithrombotic agents. Doctors in the outpatient communities faced with thousands of patients calling and begging for help have innovated. Dr. Zelenko is one in New York in the middle of the calamity in New York who was a early innovator. I summarized these and published them in the American Journal of Medicine, the synthesis of the principles of randomized trials and observational studies. And this algorithm has been updated multiple times, and it provides a framework for new drugs and agents to be incorporated in an early ambulatory treatment approach. I've reviewed every report from real-world data from American doctors who have innovated and faced this problem. And I can tell you that they are achieving rates of hospitalization and death less than 3% for high-risk Americans over 50 with multiple conditions. Most doctors can achieve less than 1%. With no treatment in the United States right now, an individual over 50 with medical problems faces a 7% rate of hospitalization and death. Someone in their 80s, that skyrockets to 40%. I can tell you as a doctor I have always treated high-risk patients with the best tools available. And I looked at all the evidence. When it was obvious that AIDS drugs didn't work, I didn't use them. But hydroxychloroquine, ivermectin, if I had favipiravir, I'd combine it with other drugs. And then steroids. That should be non-controversial. Doctors should be using corticosteroids in patients and outpatients. They're supported by both inpatient and outpatient studies, as well as blood thinners. What doctor would not help a patient who's at risk for a catastrophic stroke that occurs as a complication of this condition? So I can tell you right now, I'm not asking for permission to do this, but I'm asking for your help. I'm asking for the government to organize all government agencies that are related to this to assist doctors rapidly with their innovation and their compassionate care of patients with COVID-19 at home, because we can prevent hospitalization and death, and right now it's the only option on the table. Thank you.
Yet doctors who have had the courage to follow the Hippocratic Oath and use their off-label prescription rights to treat patients using hydroxychloroquine have been scorned, and state medical boards have threatened to withdraw their licenses. The same has happened to pharmacists filling prescriptions for the drug in some states. Will those using ivermectin or other off-the-shelf drugs being used off-label to treat COVID patients suffer the same fate? Why has there been such resistance to low-cost, off-the-shelf therapies that might stop the progression of COVID-19 and help keep people out of hospitals and the intensive care units? This year, Dr. Risch researched the efficacy of 7 outpatient medications for the treatment of high-risk COVID-19 patients in 42 hospitals across Brazil. Dr. Risch.
Senators and colleagues, thank you very much for convening this hearing. We all understand the endemic disease that we are facing and that we have to face head-on and not hide from it, hoping that it will go away. And so I'm going to give you my perspective on this. In May of this year, I observed that results of studies of a drug suggested to treat COVID, hydroxychloroquine, were being misrepresented, but what I thought at the time was sloppy reporting. We've heard from Dr. McCullough how COVID disease progresses in phases, from viral replication to florid pneumonia to multi-organ attack. Viral replication is an outpatient condition, but the pneumonia that fills the lungs with immune system debris and is life-threatening is hospitalizable. We've also heard how each phase, each pathologic aspect of the disease has to have its own specific treatment, how those treatments are derived from the biologic mechanisms of the disease. Thus, I was frankly astounded that the studies of hospital treatments were being represented as applying to outpatients, in violation of what I had learned in how to treat patients in medical school. We're now finally coming to address why over the last 6 months, our government research institutions have invested billions of dollars in expensive patent medications and vaccine development, but almost nothing in early outpatient treatments, the first line of response to this pandemic. And it's not that we've lacked candidate medications to study, we've had a number of promising agents. But I think that the early on conflation of hospital with outpatient disease served to imply that treatment of outpatient disease had been studied and found ineffective. This illogical premise motivated me to look at what actually the evidence for outpatient disease and its treatment were. So I want to reiterate that we are considering the evidence for early treatment of high-risk outpatients to prevent hospitalization and mortality. And that's it. I'm not talking about inpatient disease. That's a totally different consideration. I'm talking only about outpatient disease. So this is treatment starting in the first 5 days or so after the onset of symptoms. Treatment of older patients or patients with chronic conditions like diabetes or obesity, heart diseases, lung diseases, kidney diseases, immune system diseases, survivors from cancer, and so on. These are the people who are most likely to die from COVID, and they are the people most in need of protection. So in doing my research, I sought to obtain reports of every study of every medication pertaining to early treatment of high-risk outpatients. I monitor the literature daily, which is a task. And what I have found is actually remarkable. What I've observed is that while there have been positive reports of a number of drugs, every study of the outpatient use of one particular drug, hydroxychloroquine, with or without accompanying agents, has shown substantial benefit in reducing risks of hospitalization and mortality. Azithromycin, which is the most common antibiotic used in children, was not established by randomized controlled trials. The great majority of drugs that are in use today were not established when they went into widespread use with randomized trials. Many of them had randomized trials later, but the establishment and use of drugs is not always done on the basis of randomized trials, but on the study with other kinds of studies. And thus, the idea that only randomized trials provide trustworthy evidence is a simplistic notion that sounds good in theory, and perhaps Dr. Jha later may tell you that it's what many doctors believe, but this idea does not stand up to the body of medical studies and data that addresses it. And in fact, we have large amounts of empirical data looking at the difference between non-randomized and randomized trials. Dr. Tom Frieden, who was previously the director of the Centers for Disease Control, in 2017 wrote an extensive essay in the New England Journal of Medicine showing that non-randomized trials and randomized trials provide equivalent compelling evidence, equivalent evidence for the efficacy of treatments. So could you please enter the Frieden article into the record? Underlying this was a gigantic meta-analysis of meta-analyses, what I call a mega-analysis, done by the Cochrane Library Consortium, which is a British organization formed to organize evidence-based medical research. The Cochrane investigators examined what involved tens of thousands of study comparisons. This is a gigantic amount of data between randomized trials and their corresponding non-randomized counterparts. And when they compared these two kinds of studies, they found that they arrived at virtually identical conclusions. And please enter the Engelmeyer study also into the record. This evidence is why well-performed non-randomized trials are every bit as much of a gold standard today as the randomized trials you've heard of. This is empirical data, not opinions. This is empirical data. So what did I find when I investigated hydroxychloroquine in early use among outpatients? Right. The first thing is that this drug is extremely safe, exceedingly safe. We know this from common sense. This is a medication that's been used for 65 years by hundreds of millions of people in tens of billions of doses worldwide, prescribed without routine electrocardiogram screening. It's given to adults, to children, pregnant women, nursing mothers. Such a drug must be safe, and it must be safe when used in the initial viral replication phase of this illness, which is in fact, in outpatients, initially similar to a cold or flu. And so could you please put the Lane paper and its supplement into the evidence, into the record? This is a paper showing of more than 900,000 hydroxychloroquine users that showed no excess mortality and no increased cardiac arrhythmias. And also please put into the record my article from the American Journal of Epidemiology where I discuss the Lane paper. So in spite of the safety, surprisingly, in July, the FDA posted a warning against outpatient hydroxychloroquine use on its website. And they did this while at the same time, the FDA actually had no systematic evidence of adverse events in outpatients. And the website itself says that it justifies the warning based on evidence that it had in hospital patients. It justified it for use in outpatients, which is what I said before was invalid. There are now 7 studies of early use of hydroxychloroquine in high-risk outpatients, and every one of these studies has shown significant benefit. This includes 636 outpatients in Sao Paulo, Brazil, 199 clinic patients in Marseille, France, 717 patients in a large HMO network in Brazil, 226 nursing home patients in Marseille, more than 1,200 outpatients in New Jersey, 100 long-term care institution patients in Andorra, and almost 8,000 patients across the entire country of Saudi Arabia. All of these studies showed about a 50% or greater reduction in risk of hospitalization or death. And in fact, the Saudi study was, as I said, a national study, and it demonstrated a 5-fold reduction in mortality for hydroxychloroquine plus zinc, the two of them used together, versus zinc and standard of care alone. And none of these studies have shown a single fatal cardiac arrhythmia among the thousands of patients that were treated in these studies that was attributable to hydroxychloroquine. And in fact, in addition to this, there have been 6 outpatient randomized controlled trials. We've heard a lot about this. These trials individually were small and incomplete and were stopped early, but together, when analyzed together, as we did, they show a statistically significant reduction in risk, and that's what matters. So that's the Ladapo paper, if that could be entered into the record also. So this body of evidence for hydroxychloroquine dramatically outweighs the risk-benefit ratio for remdesivir, for monoclonal antibodies, and for the difficult-to-use bamlanivimab that FDA has approved for emergency use authorizations while denying the emergency use authorization for hydroxychloroquine. This is an egregious double standard that FDA did on hydroxychloroquine that needs to be overturned immediately and its emergency use authorization application approved. I'm restating that every outpatient study of hydroxychloroquine has shown benefit. There are no studies, as far as I know of as of last night, that are of high-risk use in outpatients that do not show benefit at all. So now we spent the last 6 months with formal government policies and warnings against outpatient treatment. The government has invested very large amounts in vaccines and expensive new treatments, which have yet to be proven, while there's been almost no support for evaluating inexpensive but useful medications. 250,000 Americans have died from this mismanaged approach. And even if we find that the vaccines eventually work effectively and safely, as we all hope, myself included, people will still get sick and die, and early outpatient treatment is still and will be continuing an essential part of ending this pandemic. Thank you very much.
Why has there been such resistance to low-cost, off-the-shelf therapies that might stop the progression of COVID-19 and help keep people out of hospitals and intensive care units?
Again, thank you, Mr. Chairman, senators, and colleagues. Thank you for convening this hearing. I have a background in virology, as you mentioned, an academic background, research standpoint from work at the NIAID as a professor performing research at Harvard Medical School. After I graduated from Harvard in 1970, I became a professor there, and later at UCLA School of Medicine. About 31 years ago, I decided to go into clinical medicine, which is my real passion. I chose a rural area, underserved, where I thought I could make a difference. And I've had experience in that 30 years treating HIV, other infectious diseases, and practicing as a primary care medicine provider and being a hospitalist. My experiences during the pandemic treating COVID patients, both in the COVID flu stage as outpatients and also as hospitalized patients in the ICU, made me determined to prevent the COVID flu from progressing to the horrible, lonely cytokine storm suffering that I saw in the ICU, and I still see it. We accomplished this with what I present here today. Like everything else in medicine, the goal is to treat early. COVID patients are difficult to treat when they get very sick. The Imperial Valley, where I work, or where we work, became the COVID epicenter for California in June and July. Since early March, both in my Brawley Clinic and Dr. Brian Tyson's All Valley Urgent Care Clinic in El Centro, where I also work, over 25,000 fearful people were screened. Over 2,400 were COVID-19 positive, and we treated successfully over 1,000 high-risk and symptomatic ones. The interesting thing to me is that Dr. Tyson and I independently came to the same protocol for that purpose back in March. And we based it upon the great work from Dr. Zelenko and Dr. Raoul, actually. They're our heroes, actually. It was a triple hydroxychloroquine cocktail, HCQ, 3,200 milligrams over 5 days, azithromycin or doxycycline, and especially zinc, which is often left out in the studies. The cocktail is best given early, as Dr. McCullough has indicated, within the first 5 to 7 days where the patient is in the flu stage. The timing of the drug is when the virus is in a very active maximal replication phase in the upper respiratory tract, and our goal has been and still is to prevent it from entering the lower respiratory tract and to prevent hospitalization. And we achieved this in over 1,000 patients. And that was involved reevaluating them at 2 to 3 day intervals. We blend in corticosteroids and prolong the HCQ treatment for 5 or more days if symptoms warrant, but they generally did not and do not. We use it especially in the high-risk individuals, as Dr. McCullough indicated, those over 50 to 60, those with comorbidities, or actually in anyone with moderate to severe flu symptoms. We want to avoid the long COVID syndrome in all patients that happens after they recover. The healthy do not need the treatment. I used this regimen to treat 31 elderly nursing home residents in an outbreak in June, and 29 recovered fully. The drug works mechanistically through multiple actions. The ionophores HCQ, the gun, and zinc, the bullet. HCQ blocks the sigma-1 receptor and has several other direct antiviral effects. The antibiotic also has an antiviral effect and potentiates the action of HCQ and zinc. As additional anti-COVID agents become available, they can be added to this regimen to enhance its efficacy. And we are routinely now combining ivermectin, which you mentioned, Chairman, in a quadruple HCQ IVM cocktail with excellent results, since ivermectin is safe and has a different anti-COVID action. This becomes analogous to the use of multiple agents for HIV treatment. Monoclonal antibodies from Regeneron and Lilly will be suitable also when readily available. The results are consistently good, often dramatic, with improvement within 48 hours. We wouldn't have stayed with this if it weren't helping people and always reliable. We've seen very few hospitalizations. We've seen not a single negative cardiac event. Our experiences are in line with all the studies that Dr. Risch has mentioned concerning early use of the HCQ cocktail. Let me be clear. This is only about the science of viral replication, the science of the stages of COVID, and the science why early treatment works. And early treatment has led us to actually try to communicate our approach. And we think it should be on a national level. We wrote a letter with my colleagues to the president, a letter to congressmen, a letter to the California Health Department, an open letter to Dr. Fauci, and a national plan for COVID-19. As we describe in the national plan, this approach would be part of the solution to the pandemic. Protect the vulnerable, and if high-risk individuals get sick, there is a solution for them with early treatment with the antiviral cocktail. If early treatment becomes widely available, people will be much more confident going back to work and sending their kids back to school. Thank you.
But when you look at the broad consensus in the American scientific community, basically the scientific consensus is very clear that hydroxychloroquine is not effective. Now, when we have looked at it in the outpatient setting, and I started with this in my testimony, we don't have great data on the outpatient setting. We have a small number of studies. But the best one of those show that it doesn't work. Could we get better data? Absolutely. And so, Senator, I would love it if you would push for better quality randomized trials.
By the way, I have, and they wouldn't do it. Okay, I've had a direct pipeline to Dr. Hahn, and I cannot get them to do it, which again begs the question, why not? That's why I say this has been an enormous dereliction. And again, what I would say, you can maybe turn to those different places, but as a patient myself, I wanted to get a hydroxychloroquine and I couldn't get it. Okay? I think I should have the right to try in dealing with my doctor who I trust. I'm sorry, more than some of these people who are so outside the circle of empathy, and for whatever reason, again, I'm sorry, it's just me. I question the fact that because this cocktail costs about $20 and remdesivir costs $3,000, that maybe there's a little bias, maybe there's a little conflict, maybe there's a little agenda that's outside of really what's treating a patient when you're in the ivory tower and you're not dealing with sick and dying and ventilated patients. Why has there been such resistance to low-cost, off-the-shelf therapies that might stop the progression of COVID-19 and help keep people out of hospitals and intensive care units?